Hello, my name is Travis Campbell. I am presenting today the Obesity and Cancer Patient Education Quality Improvement Project for my hospital in Goodyear, Arizona. First of all, let's talk about what is obesity. Obesity is usually categorized as a BMI of greater than 30. BMI is a person's body mass index calculated using their height and weight ratios. It is an important aspect to cover with patients, but is often overlooked and uncomfortable to talk about. So, what's the big deal about obesity? Well, from 1999 to 2018, the CDC's statistics show that the prevalence of obesity increased from 30.5% to 42.4%. Obesity rates are higher in poor neighborhoods compared to wealthier neighborhoods. Some practices consider a patient's BMI as one of their vital signs, as they should. The problem is growing, though. Obesity is such a slow growing problem, but it isn't going away. It is often easy for patients to ignore as their bodies adapt to heavier weights and the issues they have with weight. It may be uncomfortable to talk about for providers, but they need to do their part in bringing it to the forefront of patient discussions. So, what are the health risks associated with obesity? Many of them are known. The big ones, of course, include diabetes, heart disease, stroke, but one that isn't talked about enough is cancer. There is a link between obesity and certain types of cancer that is well established. It includes esophageal cancer, pancreatic, colorectal, breast, endometrial, and kidney cancers. Why should it matter? Well, when it comes to cancer and obesity, a lot of times patients feel a loss of control. This can help patients help themselves to gain some sense of control, to realize there's something that I can do to not only help myself, but to help my family members. There may be more than genetics or outside environmental factors that could help them understand that there may be something more that they can do for not only their family members, but also for potential future cancers, as there have been shown a reduced recurrence rate in patients that have a lower BMI for cancer. So when it comes to the three phases of cancer treatment, there are three main focus areas for cancer treatment. They include chemotherapy, radiation, and surgery. Now, one note when it comes to surgery, reducing the BMI of a patient can significantly improve their surgical outcomes by reducing wound issues, helping the patients be able to get out of the hospital in a routine time, and having less blood clots, things like that are considered improved surgical outcomes. So how to get this info to our patients? At the cancer center I work at, the Cancer Treatment Centers of America Goodyear campus, there's a very clear route patients take when they come to our center. There is no emergency room, so they have to make an appointment. The intake nurse they speak with on the phone discusses with the patient what cancer diagnosis they have and sets up the appropriate appointments. The very first appointment they have is the intake appointment with the intake staff, which includes an internal medicine doctor, an oncology nurse, and a medical assistant. The internal medicine doctor then makes recommendations after this appointment for which oncologist and surgeon, if appropriate, the patient will see. There's a great opportunity here for teaching. And our hospital does a very good job of getting patients scheduled and into these three phases of cancer treatment. But there needs to be improvement in educating patients, which can include educating them on the reversible risk factors, including obesity. I will use the Plan, Do, Study, Act improvement method to evaluate this issue and make improvements in this area. My plan includes identifying the staff involved in the intake process when new patients arrive at the hospital for their first consultation. I will work with these staff members to create the pamphlet that will discuss overall cancer causes, including a lengthy discussion about the relationship between obesity and cancer. The pamphlet will also contain information about the improved surgical outcomes associated with lower BMI. There's a lot of power in a pamphlet. This pamphlet that will be produced will help patients understand the association of obesity to cancer, as well as the risk of postoperative problems that can be minimized with weight loss strategies and resources for patients. This project will include instructions for providers on how to best bring up this pamphlet in a very matter-of-fact and helpful way. So to continue my plan, there needs to be provider training, especially for these intake internal medicine doctors and the nurses and the medical assistants to reinforce this teaching. For this pamphlet to be effective, it must be given out at the intake appointment when patients are at their most eager to change. To implement this pamphlet program with the new cancer patients at our cancer center, I'll have this trial program run for 1 month to see the effect of the program. I'll follow up with the patients to see what their overall view of the intake process and see what their view of the pamphlet was in particular. I'll study the results of the survey with these patients that were part of the 1-month trial. I'll compile the results of the surveys, present the results to the staff involved, and identify any areas of improvement to the pamphlet or in the delivery of the pamphlet and make any necessary changes. As far as putting this into action, I want to make the obesity and cancer pamphlet a standard part of the intake process and also meet quarterly with the intake staff to see any fine-tuning changes that need to be made. There will need to be some management skills involved. I'll need to make a very clear communication plan. I'll need to have communication between the intake staff and myself to make sure they understand the changes to the intake process in the pamphlet. We'll also need to have communication with the patients involved to make sure and listen to their concerns and or suggestions about the pamphlet. The end goal is to educate patients and give them a sense of control, have lower recurrence rates for them, and better surgical outcomes. The timeline will run from September 2021 through February of 2022 with quarterly follow-ups. There will be completion of the pamphlet, then presentation of the pamphlet, training, rollout, and follow-ups, as you can see here. Here are the references associated with this presentation. Thank you.